Thank you for joining us for PHC Research Week Day 2, where we are going to be looking at emerging evidence from PHC research. My name is Aku Kwame. I'm a technical officer with the Alliance for Health Policy and Systems Research, and I'll be moderating today's session, where we are going to be looking at what is known and what still needs to be known about PHC research. We will look at some insights and look at some challenges on how we advance the research agenda for primary healthcare. So let me begin with a few housekeeping details. If you have any questions for any of the panelists, please feel free to use the question and answer button throughout today's session. It's at the bottom of your screen. And this is also to inform everyone that this session will be recorded. So we will be able to post this session to the Alliance website to be able to be viewed afterwards. Now, today is the second day of PHC Research Week. We hope many of you were able to join us yesterday, where we launched the special theme of the WHO Bulletin on PHC. Today, we are presenting different perspectives on the research agenda for PHC. And tomorrow, we'll be moving into a policy roundtable on what this evidence needs to be moved into policy action. So we hope that you were able to join us yesterday. We hope that you'll stay with us today, and we hope very much that you will join us on day 3 as we round the week off. This week is being hosted by the Alliance for Health Policy and Systems Research in partnership with the WHO Special Program on Primary Healthcare. For today's session, we will start with opening remarks, and I will introduce each of the speakers in turn. We'll welcome Dr. Abdul Ghaffar, who is the Executive Director of the Alliance, to give some welcome remarks and position today in the overall week. We have 4 great presentations, and we're thrilled with the panelists who will be joining us today. And I will introduce each of them in turn, but we have different perspectives that we're presenting today. Historical perspective, looking at evidence that shows that Alma-Ata was not in fact a myth, and looking at some country cases that were able to use Alma-Ata as foundational to their health systems development. We have a presentation from a country primary healthcare case studies, primary healthcare system case studies called PRIMASYS. We will take a look at what it takes to develop a global research consortium for PHC research. And then we'll also look at a global level perspective on what this all means in our current context globally. We have a discussant who will then tie some of the emerging themes from the various presentations and really stimulate us for participation from all of you, where we'll be welcoming your questions, your comments, your perspectives. And then we'll close today with some closing remarks from the special program on PHC. Now, let me introduce and welcome Dr. Abdul Ghaffar, who is the Executive Director of the Alliance for Health Policy and Systems Research, to give his opening remarks. Dr. Ghaffar, welcome, and over to you.
Thank you very much, Aku. So thank you for your kind words. And it is indeed my pleasure and real honor to welcome all of you, especially the speakers. I have the pleasure as part of the Alliance team to work all the 4 live presenters. And I just want to say that we have learned from you, but we have benefited from your wisdom, and we really appreciate your continuous support, not to the Alliance, but overall field of the PHC research. Our interest, obviously, that Alliance was established, that there should be more knowledge to understand how can we have the better and the stronger health systems. And we believe the PHC systems and PHC programs or PHC designs or PHC access, especially with the communities and the people, it connects all the dots which we need to have if we really want to have better health, not only the diseases, but also the determinants of health. But it should be decided by the people, for the people. And we are very happy that we have this presentation, and we are looking forward to hear from you. And this is something, the service you have been doing, and we are very happy that you are continuously helping the global health community, PHC community, and the Alliance community. So thank you, everybody, and thank you to my team. Keep it up, and I will now turn it back to Aku. Aku, over to you.
Dr. Ghaffar, thank you very much for those opening words that position our session today. Thank you very much. So I'm delighted to present our first presenter, who's Professor David Bishai, to give us a look at historical evidence on how countries have achieved Alma-Ata and the declaration there. Now, Professor Bishai is a professor of health economics at Johns Hopkins University, Bloomberg School of Public Health in the United States. His research concerns the economics of local health departments and their impact on population health. He teaches online courses on health systems, health economics, and economic development. He is past president of the International Health Economics Association, and Professor Bishai is also a co-editor of a recently sponsored Alliance book that looks at how countries have achieved PHC. It's called Achieving Health for All. PHC in Action, but I believe that Professor Bishai will make mention of that book. So Professor Bishai, delighted to have you, and over to you. Thanks so much.
Thank you, Aku. So let me get through what I want to talk about today. I would like us to understand that there's a common understanding that the Alma-Ata Declaration was impractical and needed to be replaced by clear-headed vertical programs called such as growth monitoring, oral rehydration, vaccines, that we should not aspire to comprehensive primary health care. I will show some evidence that that myth was wrong and crossed out, because I will show you countries that actually did what the Alma-Ata Declaration said was impractical. And we'll talk about the relevance of primary health care for the control of COVID-19 and why that matters and what we all can do. My remarks today will be drawn from our new book, just in time for your holiday buying for Christmas gifts. But instead of waiting for Amazon to deliver it,
Prof. Bishai, you've just gone on mute.
The book is now available to you in the chat box for your reference. So let me go to the next slide. The myth that I'm about to talk about, this myth that Alma-Ata was impractical, started 1 year after the Alma-Ata conference, when a meeting came to Bellagio hosted by the World Bank, UNICEF, USAID, and Rockefeller, and they all gathered around the premise that PHC is so daunting. It means that we Western donors have to do everything and finance everything. How can they pay for everything? And so they were very concerned that they would have to do it all. And so they came up with selective primary health care as a way to do just a little bit. But this northern perspective on PHC that started the myth has been carried out even today. And now when donors talk about primary health care, they're very uncomfortable thinking that they will have to finance every little bit of what gets done. But as we'll find out today, a lot of primary health care isn't doing everything. It's being a community that can do things and unlocking local resources and community capabilities. Next slide. So there were many countries in the book that did realize the Alma-Ata vision. We only had the space and time to discuss the ones shown. I will have just a minute to talk about what we learned from Nepal, but all of these are discussed in detail by my co-authors in the book. And many other countries are going to come to our attention in the special issue as well. But let me tell you a little bit about what we learned from our co-authors. In Nepal, we learned that following the Alma-Ata Declaration, the country was invested in building a spokes and hub network. Our co-authors, Kedar Baral, Nadia Diamond-Smith, and Rita Thapa described how they went through getting the highest levels of the Nepali government to be committed to a primary health care approach. Next slide. This idea that there would be hubs and spokes is shown in this slide. You see at the center in the circle, there is a municipality which is serving these smaller wards, which are shown by the triangles. The sub-health posts in each ward would actually do the multisectoral convening down at a small level, a community of 1,000 or so people. And FHCV stands for Female Community Health Volunteers. They would go door to door, creating social networks that kept their ward together and kept them thinking about the determinants of health all together. So let me show you what was happening in each one of these triangles. Next slide. Down at these, inside the health post, we would have a primary healthcare outreach center linking to the Village Development Committee. So they were tied into the strategies being developed with livelihoods, with agriculture and commerce and roads. That was tied to the thinking in the primary healthcare outreach center. So immediately, you don't just stay in your health facility taking care of sick people. Part of your job is thinking through what can our community do about the social determinants of health? What can we do about the air and the water and sanitation happening down at the periphery, not left for Kathmandu to settle, but it was the job of everybody in public health. Next slide. At these sub-health posts, we would have child clubs, water users, mothers groups, and they were all linked together in multisectorality. And these would be at the level of about 1,000 people where these sub-health posts were. Next slide. Very quickly, why is this relevant? Having a structure like this, where you don't say the only thing that makes us healthy is the government-funded clinic, where you say we all make ourselves healthy, where you have resources in the form of health volunteers, where you've already reached out across sectors, you have the ability to be flexible. You have the ability to rise to complex challenges. So the primary healthcare strategy that Nepal built really pre-discovered the operational framework by invoking all three of these bulwarks of the framework. Next slide. So these flexible assets are part of how the countries we discuss in the book were able to address the social determinants and do a promotion and preventive strategy to health. Because the community health workers were going around to every household, there was a development of trust. Door-to-door, face-to-face conversations build trust, and you can see how important they are in responding to COVID-19. Other sectors were constantly being coordinated, schools and water and agriculture, and you can see how important that is for COVID-19. These are structures that naturally promote and support health equity, naturally bring in the underserved groups, because you don't wait for them to come to a clinic after they're sick. You are going to their home with a community health worker strategy. Next slide. So I hope I've stimulated your appetite, and I hope you do take access of the book, which is available to you in the chat box. I look forward to your questions.
Professor Bashai, thank you so much for getting us started. A lot of stimulation there and food for thought, so thank you. And I know that we will have a rich discussion in the Q&A time. Now I'd like to invite our second speaker to speak, Dr. Erasmus Ogongo, who is a Foundation Fellow of the Ghana College of Physicians and Surgeons. He's formerly been the Regional Director of 3 regions in Ghana, the Upper East, Upper West, and Eastern regions, and was also the former Director of Policy Planning, Monitoring, and Evaluation at the Ghana Health Service. Dr. Ogongo was a co-author on the Ghana case study for PRIMASYS, and we're delighted to have him with us today. So Dr. Ogongo, you're welcome, and I give you the floor. Dr. Ogongo, you may be on mute, so I'll ask you to unmute yourself and go ahead. Dr. Ogongo, you're still on.
Yeah.
Wonderful.
Good.
Yeah, please go ahead.
The Ghana PRIMASYS case study is one of the 20 case studies in low and middle income countries that were coordinated by Alliance for Health Policy and System Research. And this case study was conducted with the support of a number of actors in the country, but it was based at the Faculty of Public Health and of the Ghana College of Physicians and Surgeons. Next. Yes, this diagram portrays the whole system, primary healthcare system. Ghana has a pluralistic health system with PHC as its foundation. It generally has 3 levels in terms of primary, secondary, and tertiary. But the district level is what is required as the primary healthcare. This is also further subdivided into the district level itself, where we have the district hospital and district health management teams. Then the sub-district level, where you have health center or clinic with a team. And then the community level, or what we have developed at the CHIPS zone level. In terms of policy and planning, this is well coordinated from national level to the lower level in terms of the fact that all our policies highlight primary healthcare at the district level as the foundation of our health system. And priority is given to developing those areas. Then in terms of, and then when you come to the various levels, in terms of the leadership and governance, there are structures involving the local communities and other stakeholders to support the delivery of services. For instance, the district level, we have the district health committee that is advisory to the district health management team, consisting of various actors, religious bodies, the chiefs, and other related community opinion leaders. At the sub-district level, similarly, we have such teams existing. The special flagship program is actually at the community level, which is the foundation of the primary healthcare system itself. And that is where, after a study in the 90s, we come out with a system that if there is partnership between the community and then the health sector, and we place trained health workers in that community to work with them, they will produce the results that we need. And in fact, that research actually documented successes, and it was tried in other places, and it has become policy since 2000. And we have been modifying it as we learn over the last 20 years. In terms of service delivery, as I already indicated, at these levels, services are integrated. At the district hospital, apart from the curative services, there's a public health unit that takes care of the public health services, plus maternity services. At the sub-district level, we equally have the same integrated service delivery. And so to the lower level. The fact is, in some situations, some services are not all that integrated. For instance, mental health has been created as a service, and we are still making efforts to make sure that it's properly integrated. Occupational health is not properly integrated into the system in terms of service delivery. When we look at human resource, that was one of the major challenges, but fortunately, in the 2000s, we were able to actually liberalize education, at least health workers. So we have had a lot of production of the requisite health personnel. The only challenge now is actually redistribution to the disadvantaged areas, because people don't want normally to go to places that are not deprived. In the area of service, in the area of information and research, we have a very robust digital health information system, the DIMS. Unfortunately, it is only the cumulative data. And currently, there is what we call the e-tracker software, which is trying to pick primary data from clients so that it will help, so that it can help in terms of producing resources, information for both management of cases, as well as providing the planning and monitoring and informing policy. Research has been very key from the beginning of our primary healthcare. I must say, before in 1978, Ghana had already developed its first PHC strategic paper based on comprehensive approach, based on these levels that I've indicated. And this paper was informed by 3 previous studies that actually informed the development of that strategy. Again, when we came out with our chief strategy, it was the same true evidence that we had to come up to inform policy. Health insurance equally was also based on research. When we started having problems of financing, that was something that was started with community health financing schemes. And later on, we tried a pilot in one region and finally come out with the National Health Insurance Scheme, which is currently one of the flagship programs for the achieving UAC and the Sustainable Development Goals in the country. I must say that these are without challenges. Financing has been the biggest challenge because financing, there are 3 main sources here. The government, the development partners, and the private, and most of them out of pocket. In Ghana, the out-of-pocket payment is far higher than the WHO recommended 15 to 20% of health expenditure. So that is a major problem. In addition to that, the National Health Insurance, which is a proper insurance, a number of studies have shown that it appears not to favor the disadvantaged, the poor, because those in the rural areas are not having the facilities and they are not able to register as compared to those in the cities. And that is an area that the government is also working on to see how it can be reformed to prioritize primary health care. The major challenge here is, I think, political will to do something about it. Unfortunately, that is not yet forthcoming. And a lot of people are getting a little bit dissatisfied because the financing is inadequate and reimbursement of this level is also not forthcoming. Particularly, they tend to reimburse the higher levels who have large volumes of services and cost, whereas the chiefs, the sub-list level, which provide services to a large population, yet their expenses is low, they are not able to provide them. So, as I indicated, the evolution is from the pre-PHC period. I've already mentioned that there were those 3 districts. Then the last, from 1979 to 1999, that was where we had a big initial setback when we started the implementation. Financing was a big issue because of economic and political crisis facing the country at the time. And as the first speaker said, the comprehensive versus selective debate almost put a nail on the district. Fortunately, that one of the architects of the PHC report paper became the technical head of the Ministry of Health from 1986 to 93. And in fact, marvelously, he transformed the system from a vertical programming system to a horizontal system where we had national level supporting regions and regions supporting districts. And he made sure that he established the district health system in every district and provided programs for strengthening. He developed leaders.
Dr. Gongo, I'm sorry to cut you, but we'll ask you just to be wrapping up now.
Okay, thank you. So the challenges are essentially in the area of how do we integrate effectively mental health and occupational health and improve the coordination of pre-hospital care with the institutional services. Then how do we sustain leadership and management development at the various levels? Because this is very essential. And financing, as I indicated, is a major bit. Research areas required are how do we adapt the CHIP model to support in the urban settings? Because this is a major challenge, and currently we are trying to study how that could be done sustainably. Then the issue of sustainable financing mechanism, and also the emerging epidemiological and socio-demographic transition issues arising. We need to study them and make sure that we are a step ahead of problems such as the COVID-19 that has come to bring a lot of things down. And I must say that, but not for the structure of PHC. I'm sure Ghana would have had it, response to COVID-19 would have been worse than what we have done. I think that is part of the success factors of our response. Thank you.
Dr. Gongo, thank you very much for that presentation and making links to the first presenter. I'm going to continue to invite you to just keep posting your questions in the chat box and the Q&A. I'm sorry, we see them coming and we'll be able to respond to them shortly. But now I would like to invite a presentation from Professor Lisa Hirschhorn, who's a professor of medical science, medical social sciences, and an associate director of global cardiovascular health at Northwestern University in the Feinberg School of Medicine in the United States. Professor Hirschhorn is a leading expert in implementation research. Her work has focused on better measurement of and work to improve quality in primary healthcare, in NCDs, and in HIV resource-constrained settings. She has worked to help establish the Primary Healthcare Research Consortium, building on work from the PHC Performance Initiative, and she is committed to work to increase PHC research capacity globally. Professor Hirschhorn, thank you very much for being here, and the floor is yours.
Thank you so much, Aku, and thank you so much to the Alliance and to the other panelists for having me on this panel. Next slide, please. And we can continue moving on. So I'm going to take us back a little bit in time, back to 2016-17, when we were working with the Primary Healthcare Performance Initiative and really sort of beginning to try to figure out where to do measurement and where is the improvement and where are the gaps. And has already been discussed, there's a number of really important frameworks. And this was the one that we sort of really inspired us to say, well, how do we actually think about this? Where is there more research and evidence needed beyond the places of traditional inputs and outcomes? And really, how can this be done in a way that will contribute to the growing focus and the prioritization of primary care? And this is work that was funded by the Bill and Melinda Gates Foundation with very close partnerships with a number of people who are actually on the panel as well as in the audience, and was really led by both folks at Ariadne Labs through PHCPI and the WHO Alliance. Next slide, please. So the first question was, well, what do we actually know? And we did a pretty in-depth scoping review of what the evidence was at that point. And one thing I will point out is we're in a very different era right now. A lot of the emerging evidence from the COVID-19 and the response is not coming out through the peer-reviewed literature. And it is one of the challenges I'll talk a little bit about at the end about how do we actually even define good research and evidence. What we found was we looked after 2010, building on a review by Margaret Kruk, and we found that some areas remained well researched, but more evidence was needed to know how do you actually make this transferable? How do we adapt it? What is known about other country contexts? Previous speaker even spoke about, for example, CHIPS Plus. How do you move that from a rural to an urban setting? So even within the same country. But there were also some really major research gaps, such as things like social accountability, effective information, quality management, fund flows, and district management, to name a few, really understand how can this be done and how can it be done well. And then we also found that even where there were areas where there seemed to be some pretty good evidence, there's very uneven representation based on the region and the countries, which also provided an opportunity where capacity building and increased embedded research, some work which the Alliance has really been very innovative in doing, is still needed. Next slide. So the answer is it took a village, and it took more than a village. It really took a real global initiative to begin to figure out how do we actually focus and prioritize on these areas. And so there was a priority setting meeting, really, thanks to everybody. This again is hearkening to an earlier era. We could all stand next to each other without masks, as well as Delphi for consensus building. And based on that, there was really a question about what were the general topics, which were the priorities. And you'll see a lot of these are topics which are mentioned in, for example, the PRIMASYS review that Etienne Langlois has published in the supplement. But they included issues around how do we actually do better and more effective quality management and performance measurement, safety and competency. What do we know about effectiveness and even measurement of PHC policies and governance? Critically important, the organization and models of care, what works well and best in which settings, and finally financing in terms of market structure, political economy, and also how do we get better update of evidence. And the idea was to really look at these through a number of very important lenses, which included obviously the focus on primary healthcare function, on equity, value to the end user, so really keeping this idea of integrated people-centered care with the person in the center, intersectionality or intersectoral work, systems thinking, so moving beyond the individual behavior change, and the role within the broader health system, recognizing that primary healthcare is the basis, but also lives within the broader health system. One of the other things that we really understood was it's not just sort of what is the research that's needed, but how is it being done and who is doing it? And very importantly, how does this link to how it's being used? So we actually put out a small funding, and 6 groups either funded themselves or funded to really focus on these areas for global or regional research gaps. And this has been published in a supplement. I can provide the link to that later. But to really conduct a more in-depth evidence review, and critically to include stakeholder engagement and develop priority research questions. This spanned most of the continents. I don't think we actually had Antarctica in there, but was over 70 countries because of the networks. And these included, the leads included the American University of Beirut in Lebanon, George Washington University, International Center for Diarrheal Disease Research in Bangladesh, the enormous network of PRIMAFED, the Primary Care and Family Medicine Network with the core and University of Ghent and Stellenbosch, the George Institute for Global Health with regional offices really representing more in the Asia Pacific region. And finally, the global reach of the World Organization of Family Doctors, or WONCA. Next slide, please. So all of this information was then brought together. We then had a number of meetings to actually develop what were the core vision and the mission. And the vision is to improve health through strengthening high quality, person-centered primary healthcare in low and middle income countries, achieving that through really sort of 3 key legs of a stool of developing, capacitating, conducting, and disseminating LMIC-led research, driving research to action by addressing these priority, often country-identified knowledge gaps, and looking to catalyze a global network of collaborating partners. And the core is now based at George Institute, based in India. Next slide, please. So this was really just getting off the ground when COVID hit. So it's still continuing, moving along, perhaps focusing, as you can see, shifting a little bit to COVID. So 2 of the grants that have been done have again trying to look at this idea about how are different LMICs implementing PHC team integration. So we're talking about models of care in Brazil, Uganda, and India. And then through WONCA, supporting a multinational survey aimed to understand characteristics and strategies being employed by different countries. And then with PRIMAFED to evaluate the public perceptions and understandings of COVID-19 in sub-Saharan Africa. So it's just really getting started. We invite people to enjoy more. And again, I apologize, I meant to put the website, I'll put that into the text. But again, it's this idea of what are the things that still need to be known. We need to really know a lot more about these core areas, but equally importantly, and again, I think really highlighted by some of the previous speakers is, what works and why does it work? What is transferable to other countries so that not everybody has to recreate the evidence? But I view COVID as probably the biggest contextual factor, or one of the biggest we will ever face. I think it's taught us a lot about how we need to think about how to not just look at resiliency now, but how can that actually improve what we do moving forward. So really looking forward to an ongoing discussion about how we can continue this focus of research on primary care, how we can increase and accelerate the learning that's happening between the countries, and how we can continue to very critically keep the voice of the community and the voice of the countries as we work towards equitable, quality, and integrated people-centered care. Thank you so much.
Professor Hirschhorn, thank you to you for a wonderful presentation. You raise a lot of very important questions that I know that we will come back to in the discussion. Please, audience, keep your questions coming. We've seen them. We will refer to them in just a moment. But first, I do want to invite our final presenter before our discussants, Dr. Hong Wong. Now, Dr. Wong has over 30 years of experience in health policy with a focus on health economics, financing, and systems in developing countries. He currently works as a senior program officer at the Bill and Melinda Gates Foundation, and he manages there a program on improving primary healthcare globally and understanding how PHC financial resources are mobilized, allocated, and spent. Dr. Wong also holds an affiliate professorship at the Department of Global Health at the University of Washington. So Dr. Wong, we're delighted to have you with us today, and I pass you the floor.
Thank Gago for your introduction, and thanks organizer to invite me to participate in these discussions. Certainly, the global community is a very broad community. I cannot represent this entire community to speak on this topic. Here, I just want to share some of my experience regarding my work on this area in the past few years. Please, next slide. So just let people be aware that the OECD just published a report focusing on PHC issues. This report is published probably in April this year, and we are invited to contribute one section which focuses on the primary healthcare issues in low-middle income countries, especially from foundation's angle, what the foundation currently focus on, what are the issues that the foundation care about. So we actually, along with our partners, drafted these chapters, which divided into governance issue, measurement issue, delivery, especially quality of delivery issue, financing issue, and health system design issue, which including public versus private, of course, and the innovative technology issue, and all included in the system.
It may be good that if you can speak a little louder, please.
Okay, I'm trying to close to the mic. Is that okay? Is that better?
Yes, it's better. Thank you.
Okay. So I believe this is online. I hope the organizer can find the link to share with all people and see what a foundation is doing in this space. We're not just supporting the research, but hopefully using those knowledge from the research to guide our implementations in selected countries. Go ahead, next slide, please. So here, I just want to share a few thoughts with all of us and see how we can address this research, PHC research issue. One issue is about we do need funding to support the development and the improvement of PHC. There's a lot of research already addressed this needs for additional funding, but where those funding come from, and was certainly growing up high, make everybody happy. But we quickly probably a lot of countries hit the wall because the fiscal constraint is very little potential to grow in those pie on the investment in health under allocated to the private healthcare. Another resources, and currently we are trying to focus on in addition to increasing investment, is the efficiency gains. WHO published a report a long time ago and say there's a wastage of resources 20 to 40% about the existing investment. Where those waste can be saved? Are there any evidence or research addressing this issue? So to address this efficiency issue, and so the English, I learned that the idiom save a penny each time. So if we can have a saving, we can consider there's additional resources for PHC. So we're trying to addressing those issues. For example, one example I can discuss is about the bulk purchasing of drugs for primary healthcare. A lot of countries starting practice these ways, and they found that there's a huge potential saving from bulk purchasing policy in order to reduce the drugs price, and also developing essential distribution system in order to make it more efficient. So whether there's other examples and practice and policies and research that can help the community to and the country to think about the efficiency gain. Certainly with this efficiency gain, that pave the better way to request more resources to invest in primary healthcare. So that's one issue I want to raise, highlight it about a potential research area that community quite interested in. The second one is how can we make people-centered, people at the center for the research issues. Again, when we talk about the system research, a lot of time we start with a top-down approach. We talk about the governance, we talk about financing, we talk about delivery system, and so on. However, a lot of challenge that happened at the bottom level where the people actually meet providers. How can we make our research focus on those issues that are able to make the system, make the service more available, accessible, and with high qualities. And then the top-down solution is really a solution to help those bottom-up issues to solve properly. Giving example, as a foundation, a company with, I won't name the countries, with the government visit public health centers in one of the countries. And these health centers has 8 staff members, cover 2,000 population in their catchment area. So when it's beautiful buildings, when we visit there, there's no patients, only 1 staff, 1 out of 8 staff in the facility there. And so we quickly say, where's your director there? And we would like to chat with, discuss with what we can support to improve the service there. Half hour later, this director on the motorcycle and come in and quickly say, hey, if you look at the ceiling, there's a leakage. However, we don't have money to cash to repair it, right? We are quite busy. We need more staff. Although we have a staff member, we have to reach out to facility, reach out to the villages, and so we need more staff to do the work. And so he lists a lot of issues, which quite interesting. So one of our members in the visiting group saying, so your facility is owned by the government. if this facility is owned by yourself, it's a private facilities, are you going to continue to asking for more staff? He answered very quickly, say, no, I will cut the staff in half. I will only need 4 people, will be enough to cover the service. So, I mean, this is observation we observed. There's ownership issue, there's governance issues, and there's financial issues, and whether we could develop a research agenda, operational research agenda, or implementation research agenda to help this facility to addressing this issue properly and make the service more accessible and more efficient. So this is another issue. How do we combine our top-down issues with the bottom-up challenges, and in order to address issues on the grounds? The third issue I want to raise is about how can we building the bridge between learning and action. And those is an issue emerged when we trying to develop, working with AFRO to develop a health observatory platform for health policy and system. So we know the health observatory has been developed in many continents, but not in Africa. So we were trying to figure out whether we can support Africa region to develop this one. We quickly running into an issue about the separation between learning and actions. So we found that there's a lot of learning activities going on, but those activities, learning activity, doesn't translate into actions. At the same time, so there's so many actions being taken on every day, daily based, but lack of linkage with evidence. So how can we bring those two together more closely? Which means we need learning agenda, research and learning agenda that link to the action, but the action, how we can make sure that the people who make a decision to make an action to access this knowledge, learn and use that for their actions. So this requires the research, not just looking at what, but also focus more on how, which is a lot of people, if you look at the issues we are encountering, many people already know those problems, but in terms of how to address those problems, is very little. So this is another kind of interesting area we probably want to be focused on, making sure our research, our learning actually linking to the action and looking to the practice. So those are some of my experience I want to share. I'm happy to have a further discussion. Over.
Dr. Wong, thank you very much for again raising really excellent questions. And I just want to take this opportunity to connect your last point about learning agendas and research, and to mention the fact that the Alliance's next flagship report is on learning health systems, and we'll address many of those questions. So now I'm delighted to turn over and welcome our discussant, who's going to be raising further some really burning questions, perspectives, and stimulate us for a discussion. Professor Helen Schneider, who's a health policy and systems researcher from the School of Public Health at the University of the Western Cape in South Africa. She's had a long-standing interest in community health systems, primary health care, and district health systems in the South African context, with a focus on mechanisms for system strengthening, implementation, and governance. Professor Schneider is also currently the director and Sarchi chair in health systems governance at the University of the Western Cape, and is also currently a member of the Alliance Science Technical and Advisory Committee. So without further ado, Professor Schneider, over to you.
Thanks very much, Aku, and thanks to the panelists for those presentations. The request to be a discussant was the opportunity to really immerse myself in in all of these different outputs that the Alliance and WHO have enabled. And I must say, I found them incredibly rich, conceptually, methodologically, and empirically. And I think collectively they do offer a lot for, first of all, renewing the case for PHC as originally envisaged at Alma-Ata, but also pointing to its contemporary relevance for where we are at in 2020. And I particularly appreciated the different approaches and perspectives that you've brought together in the special issue and the book and the case studies that I think is important, an important message in itself, the need for a diversity actually of thinking and perspectives in this field. So what Aku's asked me to do is to comment on what I think are some of the overall themes emerging from this. And I must say it's incredibly difficult because there is so much to say from what has been developed and this agenda of work. But I'll make a few observations to stimulate the discussion, which also draw on some of my observations from the PRIMASYS case studies that I was involved in, and also experiences in South Africa. So the first thing that seems to emerge from this agenda of work, and I think was already clear 10 years ago and 20 years ago when we were celebrating the 20th and the 30th anniversaries of Alma-Ata. The observation is that many, if not most countries, have primary healthcare as the core foundation of their health systems. Some have succeeded pretty well at this, and I think David's book is an updated inventory of some of the examples of that. And this is reflected in quite significant gains in health outcomes and life expectancies. However you want to look at performance. But I think the reality is that many other countries are still struggling with establishing comprehensive, good quality, accessible, and equitable primary healthcare as the core foundations of their health systems. That in many countries, the achievements and gains are still quite uneven. Out-of-pocket payments remain high in pretty much most settings. And the visions of empowered communities, community participation, multisectoral action, while a consistent mantra across all of these eras, I think remain, for the most part, aspirations rather than realities. And I think we have to ask why. If PHC is such an enduring idea and we are still aspire to achieve it, why we have to remake the case now for it. And I think we need to look quite carefully at the constraints to that. So I think the first thing we need to recognize is, as David spoke about, is that comprehensive primary healthcare has actually been swimming against the tide of vertical programs, selective primary healthcare that began quite soon after Alma-Ata, but really was, I think, extensively consolidated in the MDG era with the emergence of global health initiatives focusing on HIV, TB, malaria, maternal child health, that has spawned a huge number of disease-oriented programs, and in fact, quite a fragmented landscape at country level. Colleagues in Zambia recently did an inventory of all the different partners involved over the last 2 years in developing a community health strategy for Zambia. And they counted 30 different partners, multilaterals, bilaterals, international NGOs, all weighing in on the development of the strategy. and the ability to see clearly in a way through all of that, to place a comprehensive vision at the center of it, to coordinate activity, funding streams, in the light of that is actually quite difficult. I think that the other challenge to comprehensive primary health care is that while at global level, ideas such as universal health coverage and primary health care are seen as aligned and naturally complementary, actually at country level, they're often operationalized as competing discourses. So universal health coverage, the discussions of it are often about benefit packages, about systems of gatekeeping, about cost control, around provider payment mechanisms, health technology, which is quite a different language to primary healthcare, which is about participation, empowerment, people-centeredness. And I think the Ghana case study does illustrate that there's some degree of difficulty actually in marrying what's happening with the Ghana National Health Insurance and the legacy of the CHIPs and what's happened at the primary healthcare and district level. So I think that those are some of the challenges that at country level need to be faced if we are seriously to advance primary healthcare, not just as a case, but also as a practice. The second observation I want to make is, and you know, it's a truism, and the speakers have said this, but I think we need to think about what this means for knowledge generation, is that primary healthcare is embedded within a larger system. So, and what is happening in that larger system is as important as what is happening within the primary health care system with all its subcomponents and elements. That larger system includes, in many settings, the sub-district and district health system, which are important elements of governance, actually, of primary health care. And then also at the high levels of the systems, and indeed in the wider social, political, and economic context, which collectively significantly impact on the ability to realize the vision of primary health care. So the point is that contexts matter, and they matter enormously. And when we want to understand why financing is inadequate, we need to understand financing for primary healthcare is inadequate. We need to understand the system as a whole. It also points to the importance of holistic case studies. And I think Lisa made the point that, you know, the insights and evidence of primary health care has to be understood in context. And holistic case studies enable you to do that, but also when evidence is presented, it needs to be contextualized. And related to that is that primary healthcare systems are also complex systems. They consist of a plethora of actors, and I see some of the comments coming through on that, especially increasingly in urban settings where you've got a wide variety of players coming together and interacting in all sorts of ways that in the end produce a variety of feedback loops that demonstrate all the properties of a complex adaptive system: unpredictability, emergent self-organization, where non-linear effects. So intervening in those systems has to recognize their complexity, and in particular, the multiple interactions and interfaces between elements of that system, which are, I think, as important or sometimes more important than what happens in the individual elements. So what, you know, how community-based actors interface with the local health facility, interface with the district hospital and district governance, those interfaces are as significant as each of those different elements separately. And then the third point and final point I want to make is the one that Hong left us with, which is, it's not just the what, but also the how. And that speaks to the mechanisms of change and how we understand change in health systems. So political transitions, major changes in the social and economic environment create major shocks or create new windows of opportunity for substantial reform of systems. But most systems are undertaking improvement and change and reform in an incremental way. And we need to have methodologies that help us to understand the change process and to understand how to engage, how to support change and how to enable change. And I think we need to be looking at the methodologies for doing that. I think we need a much better understanding of the insides of the system, the lived experiences from providers, from users, from communities, how they see the system, their life worlds, how they navigate the system. What are the circulating norms and tacit understandings of the functioning of the systems, the deeper levels of how that system operates, the practical norms, as some people have referred to it. We need to understand relational ecosystems, how actors work together, the nature, how trust circulates in systems, who works together with the other players, how collective action actually is mobilized in these settings. And that requires methodologies of co-production that can mobilize those kinds of knowledges. I think it also speaks quite fundamentally to the forms of governance that enable change, that enable collaborative working between actors in complex local systems. So really, I suppose my key questions, Aku, would be, how do we get to a convergence of discourses? I think as Robert Martin and others refer to it in one of their papers, Kumanan Rasanathan, how do we get a convergence of discourses, UHC, primary healthcare, social determinants of health? How do we get a convergence of effort in fragmented systems? How do we think about lesson learning across jurisdictions, across different contexts, recognizing that lessons are context bound, and we need methodologies of the how, not just the what. Thanks.
Professor Schneider, thank you so much for that very thoughtful submission. There's a lot there, and you've summarized it beautifully, but raising questions around knowledge generation, raising questions around the needed methodologies, and then how you very nicely frame the end. How do we converge discourses, converge efforts, and converge lessons? So with that, I want to deeply thank all of the panelists, all of the presenters, and we have some questions. So I will pose the questions that have come in, and I will direct them to each presenter. We will ask you to be brief in your comments back. So let me just give you all of your questions and then take your responses. So Dr. Ogongo, let me start with you. There's a question here that would like to give some further details. You referred to how the PHC foundations in Ghana supported the recent COVID-19 response. And if you could shed briefly just a little bit more light on that, that would be great. For Professor Bishai, there's a question here responding to the issue you raised about trust building. And the question asks, how do we build trust with government services in communities where trust is low? Professor Hirschhorn, I want to come to you. This is a bit more of a general question, but I thought you could give us some insights with regards to how one builds a research consortium. But there's a question here on oral health and how well oral health is integrated into PHC and what the scope for dental services are at community level. I wondered if you could share some insights on how, when we're looking at a research agenda and prioritizing, how some of these perhaps more peripheral topics can be addressed. Dr. Wong, for you, there's a question around how do we balance currently the influx of external funding that is being driven to support the COVID-19 response in countries, but how do we build that, how do we balance that with also trying to develop nationally and self-reliant PHC systems? So there seems to be a tension there, and I wondered if you could speak to that, please. And then finally, Professor Schneider, just to respond to your intervention, you spoke quite clearly, raising a lot of different governance issues. And normally when we speak about governance, it is normally limited to issues of regulation and regulation of the private sector. But you raised a lot of different governance issues. And yet governance is still an area of great need, but is not very well supported in funding when it comes to trying to expand and increase resources for governance funding. So how do we think creatively about increasing the kind of resources there are to invest in some of these governance issues that you raised? So those are the questions on the floor. I'll ask all of the responders to be brief in their submissions, but Dr. Gongo, let me please start with you.
Yeah, okay. Okay, thank you very much. How did COVID-19, how did PHC supported COVID-19 response? Actually, there had been a lot of evidence from this. At a point in time, Ghana Health Service actually contracted some senior public health experts to go to the regions for 1 month to support and work with them. And they have reports to that effect. And what was very evident is that the districts took it as their responsibility, a subsystem of the national level, and applied the guidelines within the context of their district. So for instance, when there was the partial lockdown, some of those that were not affected institute measures to ensure that people coming from the lockdown areas, they were able to monitor them and identify some of the people who were affected. They also made sure that they are linked with the communities. They sensitized them to such a extent that even the community people were informing them of people who have traveled in so that they could follow up. Again, because of that, they were able to mobilize local resources even before asking for the national level. So you realize that they were actually taking it as a responsibility. And it wasn't surprising, some of these areas, they picked all the cases and followed them up and managed them. And so we did not have serious spillover from the big cities like Accra and Kumasi. So for that bit, and the leadership that we have built at that district level is also quite assuring, because they are able to work with the local government and to mobilize resources and to make them understand that it is their responsibility to ensure that the people are healthy. So maybe we need to make a more in-depth assessment and share. Thank you.
Dr. Gongo, thank you very much. Professor Bishai, I wonder if I can come to you next.
Thank you. So my question is an excellent one. It's about building trust in I think the context was in Northern India. I'm so glad that Helen's comments flagged an issue that came up in yesterday's PHC meeting and it's come up again today, that when we say comprehensive primary health care, we're not just talking about a fixed site health clinic full of sick people that need to trust the health providers. We are talking about a comprehensive mix of public health, multisectoral community engagement, and of course there are some health posts. But that mission isn't the doctors and nurses and pharmacists saying, you've got to trust me so I can give you pills. It is so bigger and different from that. And I know it always trips people up because in English and in Western countries, primary healthcare makes people think of primary care, and all we want to think about is doctors and nurses who need to be trusted. what I put into the answer box is an approach established 45 years ago in southern India, where Raj and Mabel Arole went to Jamkhed with the mission of starting comprehensive primary health care, and they built a three-way community partnership. They were going to be there for decades, and they said, we are your partners. What can we do together? Not take this pill, I'm your doctor, but what do we need to do together? If you read the article, and it's there in the answer box, and thank you for Gafar for leading that initiative. Well, the Aroles, by listening to their community, the community said, you know what we really need? We need water. We're having water scarcity, and the Aroles worked with them to dig new wells. Then they started getting community health workers that went to have face-to-face contact time with the community to talk about all of the things that concern them. So the narrative and the discussion was heavily driven by the agenda of the community. That's serious comprehensive primary health care. So instead of saying, oh, we've got stuff to give you, you better listen to us, we listen to them. This is what was worked out in Jamkhed, and that is quintessentially a South Asian invention. And we are so grateful here in the North to be inspired by the work that was done in Jamkhed. And I think all of us should pay attention to that. Make the community your partner, keep showing up to pursue their agenda, and use this magic thing of community health workers that come from the community and listen and make regular contact. So that is the quintessential way to make trust, to be there, to listen, to be valuable to your partner, and to think of it as a partnership. That's really what we've been talking about since Alma-Ata, and that is what you do to promote and prevent. You can give a person a pill, but that's not the same as what we're talking about. Over.
Thank you very much, Professor Bashai. Professor Hirschhorn, I wonder if I can come to you next.
Sure. Always have to make sure I click the right buttons. So I think that's a really interesting question. I think there were sort of two in there, which was sort of how do you build a research consortium, but also this concept of what should be included. And when we talk about, primary healthcare, what actually is included in there. And I'm going to actually take them as slightly separate, but related. But before I'm actually going to go off script a tiny bit, just to add on to, I really appreciate what Helen said about it's not just the what, but it's the how. And I would argue it's also the why. To understand why is it that things are working or not working, or that decisions were made, which brings in the last point that she brought up, which is that context matters. And I think as we think about some of these really valuable lessons that we're learning from one country, to understand what was done, how it was done, and why it was done will, I think, really inform what we need to do to be able to spread lessons learned. In terms of the question about dental, I think it's a very, very important question. And I would sort of expand it out to other areas that have traditionally been ignored or not really focused on. So for example, ophthalmology would be another one. And particularly as we start to deal with some of the non-communicable diseases, which are either worsened by, for example, poor dental care, or actually have outcomes in eye vision, such as with diabetes, and really thinking about this concept of sort of patient-reported outcomes, which is, if you're just looking at mortality, you're probably not going to pick up the diabetic blindness, you're not going to pick up some of the potential cardiovascular diseases that may be associated with poor dental care, but it's absolutely critical, and we really need to start thinking more holistically about this. And I talk about this coming from a country where getting dental care is not so easy. It's not typically included under typical insurance, but that we need to think more broadly beyond even when we're talking about sort of the doctor and the nurse, but who actually else needs to be there. And importantly, how do we do task shifting for those areas? And in the same way that there's been some very good, I think, research looking at task shifting in certain areas, obviously HIV being one of the first ones, and now moving into some of the NCDs, we need to start thinking about what are also effective ways of delivering those absolutely critical care, and not just for adults, but particularly for children who need to actually have their teeth as they continue to not just be alive, but alive and thrive. In terms of developing a research consortium, and Hong was along with us as well as Gafar for most of this journey. It's not easy. I think what we spent a lot of time was thinking about issues around governance and how do we ensure whose voice is prioritized in that? And then how do you actually understand where you are filling a gap? And I think we were probably more focused on how do we actually get the implementers. So again, this concept of embedded research to help understand where are the gaps and how do we actually work to develop them. And really hats off to Bob Mash, who's the chairman of the steering committee at Stellenbosch, as well as Praveen, who is helping run this. And I think the answer is it's not easy. Don't do it alone, and do a lot of engagement and get, as I said, the village that's needed to actually move this forward. Thanks.
Professor Hirschman, thanks so much. And thank you also for reminding us that, especially when it comes to health, this is an issue that is important in every setting. So thank you for that response. I'd like now to call Dr. Wong to give his response. Thank you.
Thank you. Again, this is an excellent question. Certainly, people hope that the donor can give more freedom to country to decide how they spend their money. However, I understood from a donor perspective, each of the donors has their own specific mission and objective they want to achieve. And there's going to be a long way to go to develop this swap approach. I knew this idea being proposed many years. There's some success experience, but mostly didn't happen. I think while we continue waiting for this kind of approach, comprehensive approach, giving more freedom to a country to use those donor money, I think from a country perspective, I think there are few things we may want to consider. The first way is, do country has a strong, strong national plan on those issues. So if you have those plan, you can help and educate donor to support your plan, national plan, because the plan actually lay out a specific goal, objectives, and which is probably aligned with what the donor want to do. So if you have that one, that would be a very good instrument to help donor to understand those issues and align it. The second one, the country has organized a strong negotiation power to actually discuss with donors. And find a way to address donors' concerns and gain more freedom to use those monies. So that's the second one. The third one, think about how to use even the vertical program funding, use it wisely to support the system development. We knew in the foundation, we always say the system money is for the program, right? System, you're not just invest on system just for building, for infrastructure, for equipment, for people's hiring or so on. But you are actually using this money to support a program, which is a lot of this vertical program within the primary healthcare system, right? Primary healthcare, probably in some country, 80% is maternal and child health, or 50%, or some is communicable disease. It's a lot program-based. But even the investment from a system perspective is additional money for the program to operate more efficiently, effectively. But I think otherwise as well, if there's the investment from a vertical program, how can you use this money wisely to support the system in order to, again, to improve your program operations? So we knew that the donors actually consider some of the vertical program has a components of of system strengthening. So those are some issues that from a country perspective can take into account while continue to discuss and negotiate with donors on those swap approach. Over.
Dr. Wong, thank you very much for that contribution. We're quickly running out of time. Professor Schneider, I did want the chance to have you respond to that question on governance briefly before welcoming our closing remarks.
So yeah, briefly, so I think Hong has outlined a governance agenda at a sort of macro level. I think closer to primary healthcare, I think a governance agenda could focus on the district health system, how to strengthen district health systems and district health systems teams, how to think about leadership, how to think about accountabilities holistically, and working also particularly at the interfaces of community participation, social accountability, and intersectoral governance. So those would all be areas to focus on in a governance agenda. There's a lot more to say about this, of course, but I'll leave it there. Thanks, Aku. Yeah.
Thank you very much. Indeed, clearly we have a lot of questions we've not been able to respond to. We apologize for that. The time is never enough, but clearly from all that has been raised in this session today, it is a note to us that indeed the research agenda for PHC systems is very much needed. And we look forward to continuing working on pushing that forward with all of you in different respects. So with that, I would like to now welcome Dr. Hernan Montenegro to give his reflections and closing remarks. Dr. Montenegro is the coordinator of the WHO Special Program on PHC, and he has worked as a clinician. He has worked within the Chilean Ministry of Health, and he's also been at the World Bank, supporting health sector reform programs across Latin America. Dr. Montenegro was formerly chief of the Health Services Organization at the WHO regional offices for the Americas, and we're delighted to have him with us today. So Dr. Montenegro, I'd like to welcome you to the floor.
Thank you, Aku. And first of all, to congratulate and to thank the excellent panelists and commentators. Really a lovely, very interesting, very comprehensive discussion that helped us all, and also to the participants for their sharp and interesting questions. I also want to thank the Alliance for the partnership in this PHC research. So I'll keep my comments very brief because I know we're running out of time. And I think I just want to add a few key elements into the discussion, complementing what has already been said, just not to repeat again, many conclusions, many recommendations and views that we certainly share. So one has to do with the issue about the gaps. And in that, I think I just want to highlight a few ones that I see, especially in the context of the gaps in the context of COVID and the world during COVID and after COVID. One is the issue of the trust that came out, and I think that's very important. But I think the COVID has highlighted us other concerns about public trust or mistrust. For instance, the issue about how people are getting informed or learn about things. So the whole issue about miscommunication and social media or media in general, how we build that and how it affects basically that trust or collaboration, and key elements have to do, for instance, with the issue about the challenge between individual freedoms and the public good, the public health, and that struggle that we see in many places, or whether there will be acceptability, for instance, for eventually a vaccine and so on. Another element that I think it's very important is the issue about the continuity of essential services while we are in a pandemic. This has been a challenge. So a lot of the resources shift to pandemic, to emergency response, but then a lot of the problems actually pile up on the rest of the health problems. And I think that's an area also that we need to look at. Certainly, the issue about essential public health functions and public health, and I think the presenter from Ghana talked about public health and how it's better integrated with the integrated health service delivery, and they're not completely divorced, but how we strengthen that forward and better linking, I think in the future, the issue about preparedness and response while we build back better. And certainly in certain contexts of FCVs, fragile, conflict, vulnerable states, the issue about how we bring together worlds that are way far apart and have to do with all of these things on the multisectoriality, which is the emergency humanitarian elements and then the development and how those things are brought together. Many people are talking about the opportunities of the COVID on building back better, but we run huge risk that all of these investments, say the vaccines, and we start rolling out the vaccines, or the strengthening, say some public health programs come as verticals. And I think we need to be very, very careful on that. My last remark has to do with the new special program on PHC. We're very delighted to announce that at the global level, the DG has announced this new special program. I think if you're familiar with this research week, this was said by the DG himself. And I think that's a very good news at the headquarters level, that this is gonna be a leading program within the WHO headquarters, working across the 3 levels of the organization with all the programs and certainly with the Alliance and other partnerships. And I just wanna highlight that within this new special program, there's gonna be a unit dedicated to evidence and innovation. And this unit is gonna further advance all the research agenda moving forward with the Alliance, with the other networks such as the consortia and so on. And the focus is gonna be a lot on implementation along the lines of what has been mentioned. They need to, the how to, and being context specific and tailored. And then an element associated with that is the issue about, in line with the operational framework, is how we measure progress. And I think there's an agenda, another gap about the metrics for measuring. And so the whole movement is it's gonna complement that. And we were gonna be producing within the next year or so, a PHC global report. And I think this is a new development, a key product that will come out from this special program. They will feed from evidence, research, case studies, and things like that. Huge opportunity. So I just think that that's what are my concluding remarks. Again, we're very excited to be a new program and to work with the Alliance and with all the people involved with research and PHC and all the institutions and the countries and stakeholders that have to do with this. Over to you, and thank you for the opportunity.
Dr. Montenegro, thank you very much for those closing remarks. We appreciate them greatly. Very exciting to hear about this dedicated unit within the special program on PHC on evidence and innovation. And we at the Alliance look forward to continuing to engage with the special program. I know the colleagues on the panel and the colleagues in the audience will also be looking forward to how we can collectively work together to support this agenda on PHC research. So with that, I want to thank everyone for your time, your attention, your inputs today, your work on moving forward this agenda. We invite you to be in touch with us. We invite you to engage with the materials. Jeff has been putting them into the chat box, so you can click, you can read the book, you can read the articles and the supplements, and we look forward to hearing from you. I do invite all of you to join us tomorrow at 1 p.m. Central European time for day 3 of PHC Research Week, where we will be crowning off the week with a policy roundtable, taking everything that we've heard over the past 2 days and now posing the question, how do we move this into policy action? So we look forward to engaging with many of you tomorrow. And with that, I want to thank you all, remind you all that this recording will be available on the Alliance website for viewing just after we end. So with that, I would like to thank you, to wish you all a good evening and a good day. Thank you very much.